when you were diagnosing or treating the cutaneous porphyrias, if you had a story in mind that was kind of touching or kind of sits with you a little bit.
I knew somebody who had CEP very, very badly, and he was a rock drummer, and he was quite a well-known one. He, of course, had CEP badly affecting the bones in his hands as well as the skin. This was somebody who had what I thought of as an amazingly high quality of life, despite these terrible disabilities, this terrible pain, lots of medical intervention, but just had an attitude that was just so fantastically positive.
Is there something that you're excited about, something that you can share about just kind of the progress that we're making into the treatment plans of just the cutaneous porphyrias in general?
It's sort of thrilling to see that all that research that's been done over years and years, which seemed to be very interesting, and we're understanding these diseases better.
But is there any advice or anything that you give your patient to say, hey, this is what you need to do to be the healthiest you can be despite?
And one thing is not do other things that might damage the liver. So, I kind of say, if you're going to, everybody has something, I've got a weakness for biscuits, chocolates, everybody has a weakness, okay?
Yeah.
But if you've got EPP, pick another weakness, pick something else. Don't pick alcohol as your weakness.
Welcome to Rarely Discussed, an American Porphyria Foundation podcast with your hosts, Andrew McManaman
and Nicole Castellano.
We have porphyria, a rare disease. Rare diseases differ greatly but share many similarities in how they affect our lives.
Being rare can feel lonely and isolating, but we're stronger together. Join us in meaningful interviews with porphyria and rare disease experts and the patients and families impacted as we connect, learn, and heal together.
We'll talk diagnosis, treatment, pain, mental health, managing daily life, and everything rare.
On this episode of Rarely Discussed, we're honored to welcome Dr. Robert Sarkany, a well-renowned consultant dermatologist from London, porphyria expert, and an appointed member of the American Porphyria Scientific Advisory Board. As the senior consultant in Photodermatology department at St. John's Institute of Dermatology, Guy's in St. Thomas Hospital, and former department head from 2006 to 2023, Dr. Sarkany has been a leading voice in understanding rare photosensitive diseases, particularly cutaneous porphyrias. His groundbreaking presentation on these conditions, including how they impact the liver and their deep historical roots too, offered one of the most comprehensive overviews we've honestly seen. With a medical degree from St. Thomas Hospital Medical School and additional research and clinical training in Cambridge and Heidelberg, this career spans extensive work in photodermatology, ultraviolet therapy, molecular biology of porphyria, and he continues to see a wide range of dermatology patients and remains an international authority in sun-related skin disorders, educating clinicians and researchers worldwide. And today, he joins us to discuss porphyria in all the cutaneous forms, what it is, how it manifests, and what patients and providers need to be better at understanding about these rare conditions. So, Dr. Sarkany, welcome to the Rarely Discussed podcast.
Thank you. It's a pleasure to be here.
And there was a mouthful, definitely, that we can touch on and go in a million different routes. So I think what I often like to ask doctors is just backing up and rewinding to the beginning and what really got you into wanting to go into this space.
So when I was quite young, late 20s, so we're talking early 1990s. I was interested. The Human Genome Project was starting. It really started from from the United States, and the sequencing of the genome and everything was genes this, genes that. It was very exciting. So I thought I've got to be in on this. It was all very exciting. So I went into a lab in Cambridge and said, I'd like to, can I do some work on an inherited disease? And they said, sure, work on this one. And never heard of it. And it was called EPP. And so, worked on the gene, the ferrochelatase gene, when it had just been cloned, and it was, all that sort of thing. And then I did that for 4 years. And by the end of the 4 years, I was, much more interested in the disease and the skin problems and the liver problems, and less interested in the genes. So I went and became a dermatologist instead. But really mainly involved with porphyrias and have been involved ever since. And things are, it's been an exciting journey actually. It's been really interesting, and especially the last few years.
And what intrigued you about just switching into the dermatology side, the skin aspect, instead of the genes?
I, I I started becoming interested in how people's lives were affected by these diseases, by the porphyrias, and also what was the link? How did the porphyrins cause the skin problems and the liver problems and the other problems that they caused? And I started getting more involved with that than the genetics. The genetics were still important, but
Mm.
it wasn't the genes that interested me. It was the porphyria that interested me.
And I know the American Porphyria Foundation kind of saw some of the speeches that you've done and the keynotes, and saw a little bit about how you dove into the aspect of how the liver's involved in the history of porphyria. So I'm curious, just for everybody listening and watching, kind of you diving into that aspect, because we don't hear a lot about that.
Yeah, I mean, sort of going. Should I go all the way back? Really?
Yeah, I mean, yeah, I think if I think it definitely puts a perspective. So I think as far back as you want to go with it, definitely by
Well,
all means.
I mean, clearly, people with porphyria have always been around. This is not a new disease, but it wasn't recognised as what it is and as porphyria until 1911, 1912, and it really started with there was a man called Gunther, and some of the people that listening, watching, who know who've got involvement with porphyria may remember that there's Gunter's disease, and it's named after this Dr. Gunter, and he was a doctor, I think, in Germany around 1911, that sort of time, and he studied a group of children who had what we would now call congenital erythropoietic porphyria. What he noticed was that these children had severe problems when they went out in the sun, as we know with that condition, with blistering and infections and severe fragility and scarring of the skin and particularly on the face and the hands. But he also noticed that they always said, and of course it was sort of obvious, that the urine of these children was not was not the same color as everybody else. It was much darker. And he sent the urine. He said there must be something in this urine that's some way related to the disease that these poor children have. And he sent off, involved with some friends of his in laboratories, and there weren't that many things you could analyze chemically from human urine or human blood or human anything in those days. But one thing that had been discovered and was understood and could be analyzed was porphyrins. They'd been identified and understood from about 1870. And then they found that, yes, the urine is dark brown because it's full of porphyrins. And he said, I think the porphyrins are causing this skin disease and the photosensitivity. And this must be because they've been born with something about them that we didn't know about genes, but there's something about them that's somehow inbuilt, and is causing the accumulation of the porphyrins, and the porphyrins in some way are causing problems because in some way they're acting in some sort of toxic way. And this wasn't really accepted at the time. It sounded far-fetched, and people said, well, how do you know? And how do you know it's significant what you found? There was another guy who was in somewhere called Königsberg, which used to be in Germany and now is part of Russia. And it's sort of way out there in the east, sort of, near Poland. And he was the chief physician in the hospital there. His name was Dr. Meyer Betz. And he said, well, let's sort this out once and for all. And he had a friend of his, a chemist, make some porphyrin. And he had that, and then he injected it into himself, and then he kept a diary to see what happened. And he said, look, if Gunter's right and the porphyrins are causing these diseases, then I'm going to feel sick and I'm going to have problems with my skin and with the sun. And nothing happened the first day. And then he records in his diary that he went across town in the tram, and the sun came out, and he said he was on the right hand side of the tram. You see, so he put his face up against the window. He said he put his right hand below the seat, and he put his left hand up against the window, and he had a very severe attack of what looks in the photographs like very similar to EPP. He had swelling and unbearable pain, swelling of the right side of his face, swelling of the left hand, and ended up actually admitted to his own hospital as a patient. And so that kind of was the proof that porphyrins, these chemicals, these biochemicals, cause photosensitivity, cause all sorts of skin problems, and that the patients in whom it was found that they were very severely photosensitive and had all these problems that we're very familiar with porphyria, that the porphyrins that accumulated in their body were what were responsible for it. So that's kind of where it starts. And then as time went on, people started recognizing different the different porphyrias, and the one of the most recent ones was EPP, erythropoietic protoporphyria, which was identified in London. It was understood that this group of patients in 1961, there was a man called Ian Magnus, and he was a dermatologist. He was my predecessor actually, and he recognised that the symptoms, the severe pain in the sun of EPP, he then found that those patients also had a lot of protoporphyrin in their blood, and link the two together.
And also for the people that are listening and watching, just to dive into the cutaneous porphyrias, because we've talked a lot about acutes on this podcast, so it's interesting to obviously get the perspective from a doctor in terms of the cutaneous porphyrias. But to put simply, I mean, could you break down the different cutaneous porphyrias? Because I think when people research them, what they find is that there's a lot of really intense verbiage that really doesn't help them understand the difference of them. So if you could simplify it a little bit.
I think the common so let's think what's more common. Probably the most common of the porphyrias that affects the skin is Porphyria cutanea tarda, and that is the only porphyria that's not inherited. Really, it's one that comes on later in life, often sort of around 30s, 40s, that sort of age, and is caused by other causes. It's strongly linked to some types of liver diseases, and some other diseases can cause it, and that is a disease that's reasonably common. It's about one person in 5,000. And that sounds very rare, but it's more common than most of the other porphyrias. And in Porphyria cutanea tarda, people have fragile skin and blistering on the backs of their hands and sometimes on their face, and those are the main problems. So that's one thing, and that's different in that it's not inherited and it starts later in life, and its cause is related to some problems that can arise in the liver in anybody. Then there's erythropoietic protoporphyria and EPP, which is a lot easier to say. It causes that is inherited, and from the age often of a 1-year-old, 18 months old, this sort of age, patients have really very severe attacks of pain when they have sun exposure on their hands, on the face, or on the tops of the feet if they're exposed. And these attacks last 3 or 4 days. And the sort of words that are used to describe the feeling in EPP are boiling oil being poured on the skin. That's very much the sort of feeling, and it clearly is very painful. A patient who I know, I met socially actually a few years ago, and he'd fractured his femur, which is the main bone in the leg. So I mean, that's a major injury. And he described what had happened. He'd had an accident, and it's a major injury. And I wished him well, and could see he was on a with a plaster cast and all this sort of stuff. And he said, the interesting thing is, he said, I was really surprised because the pain from when my bone was fractured and they hadn't set it yet was it was less than from the attack of EPP. And I knew EPP was painful. I never really understood until he said that, and I thought, my goodness, that must, I can't even imagine, because I mean the pain from fracturing the main bone in your leg must be very, very severe. So it's a disease of pain. And then a small number of people, it's quite rare, with EPP unfortunately can develop really severe liver disease, and that can be severe enough that they require a liver transplantation. And then the rarest of the skin porphyrias is congenital erythropoietic porphyria, CEP. CEP used to be called Gunter's disease, and this is very rare. There are probably 25, 30 patients in Western Europe. When that survey was done about 10 years ago, it looked like the number of patients was very small. And that can be a very, very severe disease. Some people have it mildly, but when it's severe, it attacks not only the skin, but it causes severe scarring and can eventually attack the bones in the hands, can cause problems in the face and scarring around the mouth, scarring of the nose, so really severe scarring, uh, problems with inflammation and infection in the bones, problems in the blood with anemia. So lots and lots of problems with the eyes. So that can be, all these diseases, they're all severe, but this can, when it's severe, it can be an exceptionally unpleasant disease, affecting many parts of the body, including the skin. And for severe cases, for a severe situation with CEP, bone marrow transplantation is effective, but obviously has risks. Then variegate porphyria patients, who, of course, um, they have a great concern about the acute attacks, but 20% of people with variegate porphyria uh, gene mutation have skin problems, and the skin problems are a bit like porphyria cutaneous, a bit like PCT, with the fragile skin on the backs of the hands and sometimes blistering and those sort of things. And I think those are the main ones that we come across.
And with that being said too, and you mentioned it a lot, is the liver aspect. And I know at least the porphyria community understands how much of a toll that porphyria takes on your liver. But I wanted to get your take, obviously, just how the liver gets involved with all of this. If you could shed some light on it, and just maybe even dive into the aspect of maybe what you suggest to your patients in terms of trying to
Okay.
take care of your liver despite it getting a toll taken on it. So.
Okay, so there's different ways in which it's involved. So porphyria cutanea tarda, it's the liver that causes the porphyria. It's the other way around. Yeah. So people have various types of liver disease associated with hepatitis or alcohol causing liver problems, or some metabolic things as well. But it comes from the liver, and it's because of a liver problem that you get the porphyria cutanea tarda. So it can work that way in that disease. With EPP, the protoporphyrin, which is in the blood, um, it it is toxic when you mix it with light to the skin. So it's the reason that you get that terrible pain in the skin is because there's the light penetrates the skin down to, I don't know, a couple of millimeters, and the protoporphyrin is in the blood cells, in the blood vessels, about a millimeter down, so not far below the surface. So the protoporphyrin is toxic in combination with light, so it makes sense that the skin would have problems in EPP. But what's less expected is that protoporphyrin is also toxic to the liver, even though it's dark in there. And there are certain explanations. I'm not sure that it's completely understood how it can be so toxic in the dark. But in some people, it is very toxic. In other people, they seem to have no problems. So in EPP, the great majority of people have no liver problems, but there's probably 2-3% of people who do develop severe liver problems, and that's obviously a worry, especially if the doctors can't identify who the at-risk people are. So there's it's important to for patients with EPP. They may say, I mean, now the situation with EPP is that actually new treatments are coming along to treat the skin and the photosensitivity in EPP, which is great. But even if somebody with EPP is attending a medical service which doesn't yet have access to one of those, because they're very new agents, new drugs, drug trials, all this sort of thing, it's very important that they're seen at least once a year, at least to have some sort of check that their liver isn't running into problems, because if it is, one needs to know about it and get help from a liver specialist.
And I guess in that regard too, because I know obviously you would push them off to a liver expert and kind of touch base with that. But is there any kind of standard advice or anything that you give your patient to say, hey, this is what you need to do to kind of be the healthiest you can be despite?
Okay, so that's a very good question, and I suppose, I mean, one thing is not do other things that might damage the liver. So, I kind of say, if you're going to, everybody has something, I've got a weakness for biscuits, chocolates, everybody has a
Mhm.
weakness, okay?
Yeah.
But if you've got EPP, pick another weakness, yeah? Pick something else. Don't pick alcohol as your weakness, So I think alcohol is important. And the liver does not do particularly well in people who, it's affected by diabetes, it's affected by high cholesterol, it's affected by because you get fat in the liver, you see, and in anybody, it's the liver in anybody is affected by being overweight, poor exercise and things. So good, trying your best to maintain good liver health, not have other things with alcohol or other lifestyle sort of related things that might adversely affect your liver. So have basically a healthy lifestyle, but with the focus on the sort of things that might affect the liver, and get your liver checked out, because there is a sort of if you're talking about 2-3% of people, in the end, among the 98% of people who are okay with their liver,
Mhm.
there are quite a lot of people who probably don't have an ideal lifestyle. And so there must be something that we don't understand yet about the people who develop, the small number of people who develop the severe liver problems, which may be genetically different or something. So have somebody monitoring your liver. Do the best things you can to look after your liver, for good liver health. But and also have somebody checking, from time to time that your liver seems in good shape.
And obviously, you're very well versed in the history of porphyrias and just at how far it's coming now in terms of treatment and how to deal, because we've had some EPP patients on here and just discussing the things that people don't think about. I mean, driving at night, doing everything at night, and putting your arm up on your car while you're driving, you don't want to do that, and all these little things that people don't understand they go through on a daily basis. But I wanted to ask you, is there something that you're excited about, something that you can share about just kind of the progress that we're making into the treatment plans of just the cutaneous porphyrias in general?
Well, yeah, I mean, it's brilliant. I mean, what's happening in the acute porphyrias, which I won't talk about because it's not my area, but in terms of new therapies, and in terms of new therapies for EPP in particular, it's very exciting. I mean, for somebody like me who's been involved for most of my life in this area, it's sort of thrilling to see that all that research that's been done over years and years, which seemed to be very interesting, and we're understanding these diseases better, but then patients would quite reasonably say, well, when's it going to produce results for us? And I'd say, I don't know. And it looks like it's producing results now, that there are drugs being designed and being tested in clinical trials, which for EPP at the moment. I know for acute porphyrias, a lot of that's already happened in the last few years, which are the result. They are the direct result of all that research. I mean, in EPP, there's one drug which is Scenesse, which is known as its chemical name is afamelanotide, and that has been sort of licensed and available in some countries for about 10-15 years. It's not available in all countries. It's quite an expensive drug, but in a way, it sort of seems to have sort of led the way for others. There are some problems with it in that you have to have a small minor surgical procedure on the skin on your tummy to just put below it a little pellet of every couple of months of the drug. But it seems quite effective to prevent the photosensitivity. There are clinical trials then going on at the moment, really for 3 different drugs that all do completely different things in EPP, but all look pretty promising. One is dersimelagon. Dersimelagon uh, works in a similar way to Scenesse, to afamelanotide, but it's a tablet, which is nicer. So it's easier to take a tablet than to have minor surgical procedures. And that's coming. There are clinical trials in that which are going on at the moment and which will finish quite soon. And who knows what the result is? But I think the sense of everybody is this is a promising drug, and we have our fingers crossed that the results bear out our sort of the sense that everybody has that this maybe is something that will be really useful in the future. Then we got bitopertin, which is a drug that seems to be effective from the small trials that have been done, and it's going into bigger trials. It seems to be effective for the skin, but it works by reducing the porphyrin level, and that maybe holds out the hope that it will protect the liver in people who are having liver problems. So that's very exciting. And then kind of coming up behind those, there's a drug called Port 77, which is in the earlier stage of trials, but again looks promising and looks as though we hope that it'll be useful, like the bitopertin, for protecting the liver as well as protecting the skin. So it's a very good scene, and it's exciting. Porphyria cutanea tarda, the treatments have been around for longer, but very effective. They're very, very effective treatments for porphyria cutanea tarda for anybody who's got that. And then for congenital erythropoietic porphyria, at the moment, in terms of definitive treatments, you can manage things well. You can know how to protect yourself against light and have somebody managing, sorting out the anemia and the eye problems and all those sort of things. But in terms of definitive treatments, the bone marrow transplant side of things, obviously the problem with bone marrow transplant is it's very effective, but it's it used to have a lot of dangers with it, and it's becoming more refined, the way that bone marrow transplantation can be done with stem cells and other things, and so that things are moving for that very severe but very rare disease as well. So I think things are moving in a great direction. I think in medicine generally, there is at the moment, everyone focuses on the problems, the health systems, the costs of them and the aging populations and all this. And I know all that stuff. But when you look at the number of diseases which have not had any treatment that's been effective before, where effective treatments look as though they're being developed, it's like nothing that's happened in my lifetime.
I mean, even when I first got diagnosed with AIP in 2018, it just seemed like everything was just so rare and untalked about, even though it wasn't. But then once you kind of delve into the community a little bit and understand and talk to doctors like you and just get a sense of, wow, there's actually a lot of moving parts happening in the background right now. But we just as as the people in the public eye, or all the people out there, they don't really see all that yet, and what's coming and the things like that. So it's been really cool to see the advancements even in just the last decade, because I talk to these EPP patients who are like, oh, I have to buy this special clothing head to toe, and then they're like, yeah, I've used the sunblock, but it doesn't really work for me, and all these different things that just don't work. And then they hop on something like Scenesse, and they're like, I just went outside and I didn't have to cover up. And it's amazing to hear stories like that, because again, it's one of those things where a lot of people don't understand the issues that cutaneous porphyria patients go through, because I mean, not being able to go out in the sun and do anything, I mean, that's a lot. So it is very cool to see the advancements that have been happening, to say the least.
Yeah. And it's not really going out in the sun either. I mean, if it was going out in the sun, it sounds like, well, they'd have to give up sunbathing, which is not a big deal, but it's not that. It's really having a life during the times when it can be sunny. So for us in the north, we're much further north than you. Northern Europe is like the level of sort of middle of Canada or something. And our patients have sort of 8 months per year when they really can't do anything much during if they got severe EPP during the daytime. And in the United States, it sounds like it's more like 12 months a year because you're further south. So it's a massive thing. And the problem is when you make a mistake with a disease like EPP, you don't just sort of get oh well, I made a small mistake. I went a few minutes over my time, so I'll get a half-hour attack. You get a 4-day attack. You get a full blown, the full thing. And no sleep for 4 days, and the whole thing. So making a mistake is not an option for most people with a condition like that, because you make a mistake and you get punished for it, even if it's you just went slightly over your time. So naturally, people have to become very careful and very kind of withdrawn during those times of day, really.
And for those patients, or for those people that are watching, listening, that are thinking, do I have something like this, or do I not? Because I had chatted in a previous episode, because when we talk about AIP, we were laughing that most people just say, oh, it's just an enzyme deficiency, and we don't really go into depth with it to explain what it really is. And then you have these people that are like, oh, maybe I have that, and it's like, well, probably not, but because everybody is deficient in something. So it's it's one of those things where I'm curious, just for those people listening, watching, kind of how you go about diagnosing somebody with this.
So the first thing is to, for a doctor to be familiar with, what are the, in my case, what are the skin problems, but generally what would be the problems if somebody might have variegate porphyria, we might see that, or porphyria cutaneata, or EPP, or CEP. What would I expect? And then if I suspect it, then we send off, blood tests, urine tests, for to analyze for porphyrins and see whether the porphyrin levels are abnormal, and they'll clearly be abnormal if somebody has porphyria.
Yeah, and I think yeah, people just really need to go to the doctor. I think that's the probably the biggest piece of advice.
Yes.
Because people have skin issues, and they're like, oh, it's probably just, I caught something, I rub up against something, maybe it's this, maybe it's that, I don't know. But something I also wanted to kind of dive into is just, if you could talk about a patient anonymously, kind of a story that you had that just really stuck around to you, in terms of just when you were diagnosing or treating the cutaneous porphyrias, if you had a story in mind that was kind of touching or kind of sits with you a little bit.
I knew somebody who had CEP very, very badly, and he was a really wonderful person. He was I hope his family don't mind me talking about him, but he was fairly open about his condition, and he was a rock drummer, and he was quite a well-known one. And he had, particularly in sort of 80s and 90s, he was with a band that were pretty successful, and they were sort of they weren't a household name, but they were just that one level below. They were a really good rock and roll band, and he was the drummer, and he was a good drummer. And he, of course, had CEP badly affecting the bones in his hands as well as the skin. And then after every concert, they'd do a gig, and they'd have the after. I understand. He told me they had the party afterwards, and as you do, everybody comes into the dressing room and all this sort of stuff, and he always had his hands in cold water, just to sort of, because it was really pretty painful. But he never gave up on it, and he kept going with that for as long as he possibly could. In the end, he became too sick to do that. But I mean, I have to say, he was called Mark, and I learned a lot from him about how his quality of life, I always felt, he was an amazing person. He had an absolutely terrible disease from a very, very young age. He had CP very severely, and in the end became very, very sick with it, and unfortunately, it killed him eventually. But uh, this was somebody who had what I thought of as an amazingly high quality of life, despite these terrible disabilities, this terrible pain, lots of medical intervention, but just had an attitude that was just so fantastically positive, you know.
And with that story being said too, what is just something that you find yourself learning from patients that have cutaneous porphyrias? Because I think when we talk a lot with porphyria patients, there's obviously the level of mental health that comes with all of it,
Yeah,
and just because that tends to be a huge hurdle, because it's easy just to, at the end of the day, being like, with CEP, saying, you know what, my hands are going, or parts of my face, and
yeah.
I can just sit here and just let it happen. But then you have those situations where you made the most of it. So what's something that you're learning maybe consistently from patients that you're seeing?
Well, that's a really interesting question. I mean, one thing about it is that these sort of diseases, which are there from childhood, of course, the person themselves has to suffer the pain, the anxiety, and all those sort of things. But their parents and their siblings suffer too. You know, it's not just the patients who have to deal with this. The lives of everybody are affected by these things, and that's one thing that I didn't sort of realize until quite a long way into this whole journey in a way. That for parents, but also for siblings. Siblings, their life will be changed by the fact that their sibling has been, has been ill in some way. And yeah, I mean the effect on mental health is dramatic. And I think as a doctor, it's very easy to sort of cut yourself off, and sort of make everything very technical. But then, if you try and put yourself into that, uh, into the place, what would it be like if I really, I couldn't go out in the spring and the summer, in for 6 months or 8 months, and for any appreciable time. What would it be like if I was worried that I might have involvement of this organ or that organ? What would it be like? All those things. And yeah, then you start thinking about your daily activities, and obviously there's a tremendous effect on that, and at different phases in your life. I mean, the photosensitivity is very, very difficult to manage when in teenagers. They want to be with their friends. I mean, who doesn't at that age? Later on, you can be 63, you can be as antisocial as you like when you're 63. Nobody minds. But like, life when you're a kid, but particularly when you're in your teens and your 20s, it's about other people, and it's about getting to know other people, and it's about being, having a group of friends and having relationships and all these sort of things. And if you have diseases which, like CEP, might make you, look different. They will affect your face. You can get scarring on your face, scarring of your hands, or feel different in some way. Relationships at that stage can be badly affected. So it's a kind of holistic thing. I mean, these things impact every a lot of aspects of the life of the person who has them, and of their relatives.
And I wanted to ask you too, just for kind of switching gears a little bit, but for everybody watching, listening, that maybe doesn't know everything there is about cutaneous porphyrias, of course, but I wanted to kind of ask if you maybe could share something that maybe a lot of people don't know about the cutaneous porphyrias, just in general, that maybe you learned and intrigued you, or something along those lines.
Well, that is an interesting question. So can I have a second to think about that one, Andrew?
Yeah,
Uh,
yeah,
that
it's a
is
lot.
that's an interesting thing. So I got interested way back, in how the porphyrins could cause the damage to the skin and where they were doing it. Um, and um, and I've found that interesting ever since. I mean, in EPP specifically, it's the lining of the blood vessels that gets damaged in the skin. It's not the rest of the skin. The rest of the skin, nothing very much happens at all. But the blood vessel lining is damaged severely every time anybody has an attack, and then it regenerates and everything. But while it's so damaged, it's very painful. And yeah, what is it about the porphyrins that makes them? I mean, I've just been interested in, what is it about these particular chemicals that makes them so toxic when they're mixed with light, and how does that relate to, why do we have them, and what are they for? I mean, porphyrins, we need them, in order to make heme, and we need heme to have hemoglobin and to have other things that we need in our body. What is it about those particular chemical structures that causes that? So that personally is a thing that's been interesting to me, and that, I mean, that is now very well understood. But I think it's helpful. I always like to have a picture in my head, when there's, as a doctor, when I'm seeing somebody who's got some problem, to have a picture in my head of somehow what's going on inside there. In my case, often it's in the skin, but what's going on in there, or what's going on in the liver to cause the problems. But what's the process? How's this happening? What's the connection between, these chemicals? That we've got lots of chemicals, natural chemicals in our body. What's so special about these ones? And what is it about the way that they, what happens when they're exposed to light, and all this sort of thing? And yeah, so I found that interesting, but I don't think I've communicated that very well.
Porphyrins are a very intriguing thing, because I know obviously people with porphyrias have a love-hate relationship with them, but it's interesting because I had this interview with Dr. Jonathan Arambula, who's in the cancer space, and they're utilizing to put simply, I mean, there's a lot more that goes into it than what I'm about to say, but essentially using porphyrins and hitching chemotherapy to it to drive directly to tumors.
Yeah.
And they have found that porphyrins just run to tumors, and it's a very interesting thing to utilize porphyrins for.
Mm.
And I mean, I really couldn't wrap my head around it when we were chatting about it, but it was just so interesting to almost have a good with porphyrins being used to treat cancer. So
Yeah, we've used them. There are some of the skin cancers, some of the thinner ones. There's a thing called photodynamic therapy, and for that you use ALA, which is obviously, it's one of the early chemicals in the porphyrin pathway, in the heme synthesis pathway. And you put a cream with ALA on the skin, and what happens is that the ALA is taken up by cells, and the ones that make the porphyrins out of it, a lot of porphyrins out of it, are the cancerous cells. And the reason for that is that they are more active than the rest of the cells. They're growing faster. They're doing more, and so they need to use oxygen to do that, and you need hemoglobin to get hold of oxygen, and you need hemoglobin, and you need all these heme containing proteins to do that. So naturally, those cells will be more active in making heme, and therefore making porphyrins, than other cells. So selectively, you will produce porphyrins in those, and then if you illuminate them with light, then of course you produce a nasty EPP reaction, but where you want it. So instead of damaging the blood vessel, the inner lining of blood vessels in a patient with EPP, you're damaging the cancerous cells in the skin of somebody with skin cancer. So it's a useful destruction. It hurts. It hurts just like EPP, but it's useful.
and with that being said too, I mean, is there risks that come with something like that? I mean, is that a risky thing to do, or
It hurts.
just
It's
the
painful.
it's the pain aspect?
Yeah, I don't think it's risky. I mean, that's an interesting question. Are you sort of, in some way, at risk of inducing later, more cancers later on, or something like that? I think probably not. That people have argued a bit about that, but it's painful. That's the problem. That's the limiting factor on it. But it's effective, and it's used quite widely by, you may find that you go to your dermatologist in the office, and if you've got certain types of precancers that are superficial, and there are lots of them, and in certain places in the body, that's a great treatment if it's available.
And I wanted to ask you too, just in a dermatologist sense, is for people watching or listening, just because I have you here, if you had some advice for people watching, listening, whether it's about cutaneous porphyrias or even just the general broad dermatology, I mean, what advice would you just have for people out there that maybe us as a population are doing something that is hurting our skin that we don't really realize? And I was curious to kind of throw that general blanket question at you in case somebody was curious.
So I think maybe this clearly doesn't apply to people with cutaneous porphyrias who have, you know, very good reasons to not be exposing a lot to the sun. But I think probably perhaps more in Northern Europe than in some parts of the States. But there clearly are problems with, there has been a bit of an epidemic of skin cancer over the last 30 years throughout the Western world, and a lot of it relates to sunbathing habits and to all those sort of things. So uh, sunbathing is not a good thing for people without, I'm talking about people without porphyria. It's not a great thing to do, because when you get that damage, when you're younger, in your 20s and 30s, when you feel invulnerable, and then start reaping the problems with that, in your sort of, late 40s, 50s, that sort of thing. So skin cancers are sort of essentially mostly produced by UV damage in the skin from sort of excess UV exposure. So that would be my main thing. Just be a little bit careful about that and all that. Enjoying, on holiday, think of something else that's enjoyable as well as the sun for non-porphyria people.
Yeah, it's very interesting. Just obviously with the general population in general, but just for people, because obviously when you're younger, yeah, you get in the sun 24/7, and then now you're in your 30s, 40s, 50s, and you're throwing all these serums and things on your face just to combat what you did when you were younger. So it's very interesting. But I wanted to ask you too, just while we're on this kind of generalized path, is there's been a lot of articles and things out there about sunblock, and some people are like, well, this sunblock's bad, it actually is it not good for you, and then people are not wearing sunblock and they're saying it's better to be natural in the sun, and there's all these conflicting views. And I would anticipate that the answer would be something along the lines of there's better sunblocks than others, you just got to look at the ingredients. I mean, what's your
I
perspective
think
on
that's
that?
true. I think the problem is that some of the studies that have been done in the last 2 or 3 years that have had a lot of publicity in the States and in Europe, which sort of say, that these chemicals are absorbed and they're carcinogenic and all this sort of stuff. They've been very poorly carried out studies. And there is no really good evidence that, I mean, what we do know is that ultraviolet from sunshine, it is a carcinogen. I mean, it's a carcinogen as much as cigarette smoke is a carcinogen. And what we do know is that's definitely cancer producing. The chemicals in the sunscreen, the amounts that are absorbed into people are almost certainly too low to cause any significant cancer risk at all. The problem with this whole debate is that there are, these huge commercial concerns who have a kind of interest in one outcome to this debate. You know what I mean? I mean, anybody who's operating sunbed parlors, they clearly don't want people to think that ultraviolet is dangerous. Anybody who is a manufacturer of sunscreen clearly wants people to think that it's incredibly dangerous. So there are quite sort of large commercial interests which make it very difficult to have a straightforward conversation about these things.
Right. And I also just wanted to ask you too, just I know we're trying to wrap up here in a little bit, but I wanted to ask just along the lines of maybe we've had this extensive conversation, but is there something that maybe we didn't talk about that maybe you wanted to shed more light on for people listening and watching?
I don't think so. I think one thing with the porphyrias, with photosensitivity, is that the sort of light from the sun, the bit of light from the sun that causes the problem, is not ultraviolet. Now that's what sunscreens protect against. Okay, It's kind of blue light. It's a longer wavelength. It's bluish violet light. It's wavelength number would be 400 to 420 nanometers. Now that's significant because if you're trying to protect yourself against those wavelengths of light, whether it's those types of light, whether whichever of the cutaneous porphyrias you've got, a good sunscreen may not be of any use because the good sunscreen protects against ultraviolet, and ultraviolet is not the problem in porphyria. So protection against blue violet light is not easy. One thing that's working in our favor with this is that there is a tendency, sunscreens are now being produced that are advertising that they protect against blue. And the reason they're saying that is because, and I don't know whether it's true or not, that there is some evidence, and people argue and say, well, actually, the blue light is involved in skin aging. Now, I don't know whether it is or whether it isn't, and I don't actually care because it's just useful for people with cutaneous porphyria that the manufacturers that this is they're beginning to make these sunscreens which have good blue protection against them, visible light protection for another reason. And so there's a better chance the last few years of sunscreens, particularly the ones where they'll say it's against blue light. You got a chance that it's going to be protective in some way.
That's interesting. And in terms for obviously for people listening, watching, I mean, what would be a blue light for people that don't know?
So it's just that sunlight contains all the colors of the rainbow, which is why it's wide, plus one bit that you can't see, which is heat, which is also called infrared. And the other thing that it contains is ultraviolet, which you can't see and you can't feel, but it causes sunburn and it causes all sorts of effects on whatever it comes across in biological anything living. It affects because of the nature of it. So if you look at those, and there's something called wavelength, which is the number that's used to describe the different types. So the shortest wavelengths are, it's a physics thing, are ultraviolet. Then longer are the visible light, the stuff that actually makes up the white light that we see. And then the heat is the longest wavelengths of all. So they're all the same stuff. They're all what's called electromagnetic waves, but they're all the same thing. It's just the different wavelengths of it. And the blue, which causes the bluish violet light, which is the bit of it of the sunlight that causes the problems in cutaneous porphyria, is longer. It's long enough to be seen, so it's not ultraviolet, which is invisible, but it's short. It's a shorter wavelength than some of the others. So if I had a very, very bright blue light, yeah, do you know what I mean? I mean, it was just, I had a blue filter or something and I had a torch that was very powerful, and I put that blue colored light, very, very bright, just bluish violet, that sort of color, onto the skin of somebody with cutaneous porphyria, they'd have real problems with it, whereas they wouldn't necessarily have particular problems with other types of light.
Yeah, and I know we've chatted with a lot of people with cutaneous porphyrias and them talking about having to switch some lights out in places
Yes.
where they were particularly harmful, because I think there is the misconception where a lot of people will say, oh, the sun porphyria, the one that you can't go out in the sun, but it's a little bit more than the sun. I mean, it's the aspect of all these different lights. And
Yeah.
I mean, I've talked to people who've had to talk to administrations in certain commercial buildings and said, hey, we need to change these out or cover them up. So
Yeah.
what's your take on all that in terms of lighting and things
So
like that?
the intensity of light from indoor lights generally would be simply less intense than normal daylight. So most people would have their main problems would be with daylight, but people who are very sensitive, clearly the amount of light that comes down from from interior lighting can be enough, because if it contains a significant amount of bluish violet light, then it can be enough.
And so in that sense, I mean, I'm not too obviously well versed in the lighting space, but I mean, for people that are extremely sensitive, I mean, what kind of lights are they getting at that point?
Well, I suppose. Well, yeah. I mean, so things are changing, and LEDs are now taking over from all those all the fluorescents. The fluorescents were tended to be cold. The colder the light, people talk about cold and warm light, and they're all white light, but the warm light is more yellowy red. So the wavelengths are not so blue and bluish, whereas the
Mhm.
colder light tends to be more the bluish. So if you've got a choice, I'd pick a warmer light, a warmer
Interesting.
color, if you see what I mean, because it'll be yellower and there'll be more of those longer wavelengths and less of those short wavelengths. And with the LEDs, you do have those choices now.
Yeah, they're making lights really fancy these days. You can control them from your phone and make them all different colors. So
Absolutely.
definitely a benefit. But yeah, I thought this would be a good place to wrap up. I definitely appreciate your time and of course being able to sit down and chat about this because it's not talked about enough. I mean, there's a lot that's talked about with cutaneous porphyrias, but at the end of the day, there's never enough because we're trying to raise awareness and get people to understand that
Yeah.
you know people like I said earlier to go into the doctors and get the blood test, get the urine tests, and just see what it is because I know there's a lot of people that sit on the sidelines and say, well, do I have it? And obviously best case scenario is to go to a doctor and really figure it out.
I
So
totally agree with that. And I think as there's more understanding of all these things, and now as new treatments are turning up for really distressing symptoms and complications, it's even more important to get a diagnosis. Yeah.
but yeah, and I 1000% agree because it's just I feel like there's this misconception. I've talked to a lot of doctors on the podcast where there just is this there's this tension between patients and doctors these days, and a lot of people will either think, oh, doctors are out to get me or whatever, and we're trying to bridge the gap and understand that doctors are humans too and they actually want to help. And I just to have to say that, I know it's just people have all these bad experiences, and obviously it takes a toll on everything. So it's nice to be able to obviously sit down with you, have this conversation, and
Yeah,
really
and
bring people in.
yeah, it's sort of you're right that maybe people, if they've had a bad experience with a doctor, I mean, doctors are as varied as everybody else, and they'll have their good days, they'll have their bad days. There'll be people that you meet at a party or something that some you'll really get on well with, and some you just won't. And the same will be true of doctors. So I wouldn't sort of smear us all with the same brush. I mean, there are different types of people. You may find you saw somebody and they were they gave me no time and they had no time for it, and then you don't realize that actually they have a diagnosis of their own, or their son or daughter has a diagnosis that they're having a rough time, or they just had an argument with their wife that morning. You have no idea. I mean, people are people, and you come across people, and of course when you go as a patient, you feel so vulnerable, that the last thing you need somebody who's going to give you the space and who's going to make you not feel humiliated and who's going to make you feel listened to. That's important. And if you don't have that experience, just remember that you might have it next time from someone else or from the same person.
Yeah, I think it's important too, and I know it depends on the practice that people are at when they're kind of having these issues. But I have come to realize, just understanding more of the back end, that there is a lot of scheduling issues. I mean,
Yeah.
there's a lot of patients that, of course, need to be seen, but in that sense, I mean, it takes a while to room people, and then you get what 15-20 minutes per patient, if
Yeah.
that, and then it could be going into somebody else's time, and it's just a very difficult situation that I feel for because obviously you got to keep to a schedule too at the
Well,
same time.
yeah, yes, sort of. I mean, what
Yeah.
I would say is, I mean, as you know, I've been a doctor now it's been quite a long time, actually. It's been like 40 years or something, and nearly. And I mean, I just think it is a great job. I mean, I look at other people's jobs, and I'm really happy to do it. I mean, it's a great privilege that people trust you and ask you to help them with their problems, and that sometimes you're actually able to help with their problems, and that's
Hmm.
that's a great privilege. So I mean, I think it's a great job. I mean, yeah, there are lots of administrative things one has to deal with. You know, I don't know, hospitals which won't give you the funding for whatever you want, and there's all this argy-bargy and scheduling. And I take those points, Andrew. But I mean, in the end, it's one of the oldest relationships in mankind, that you've got somebody who's there whose job it is to try and help a problem, and somebody comes with their problem, and that's a very nice. I think it's a great job. It's a real, and it sounds a bit pompous, but it's a real privilege.
I mean, it's fulfilling. I mean, you can go home at the end of the day and know that you just helped a countless amount of people. So it's definitely,
It's a
I could imagine.
it's a nice thing, but yeah, is it? Yeah, does it take up a lot of your time, and does it take up a lot of your mental bandwidth? And do you have situations that you come across that are frustrating? That's all true, but I think as a doc, for me, from my side, I'm sort of just try and home in on the essentials of the job, which is somebody comes, they're suffering, otherwise there's something that's upsetting them, that's distressing them. They come to you, you do your best to try and work out what the problem is and whether there's anything you can do to help. And if you can, well, that's fantastic. It's great, and you do your best. But I mean, I know that there's peripheral things that can get in the way of all these relationships.
But yeah, it's fulfilling. I think that's the word for it. Just because obviously there's a lot of people in there that lean on doctors and things like that to help them to be better, and we talk about it on podcasts and stuff like that. So
Yeah, I
it's
mean, I've been, I've been a patient too. I've been on the other side. I prefer being on the doctor's side, I can tell you.
yeah,
But one of the things that strikes me is how amazingly powerless you feel. You very much, and it is important, even as a doctor who's a patient who sort of thinks, well, as long as the person's, I sort of, the first time this happened to me, I ended up going to see somebody about something, and I thought, oh well, as long as they're competent, that's fine. But it's not true, actually. I want somebody who sort of validates my experience a little bit. I want somebody who doesn't make me feel stupid or small or frightened. And those are emotions that we all have when we're ill. I mean, it's unpleasant and it's frightening and it's distressing to be ill, and that applies to everybody. Yeah, those soft skills, those ancient skills matter, but having it makes our jobs a lot easier if we also have new medications where we say, well, actually, we can give you a pill for this. I mean, that's fantastic, and that's where the technology comes in, is that we'd still have to use our old skills, still have to be able to diagnose the right disease. But once you've got it, the technology at the moment is running fast at saying, I think we've got a tablet for this and we never had anything before. And that's fantastic.
to be able to obviously hear the hardships that they're going through and to be like, yeah, I can fix that.
Yeah, you can. Yeah. Yeah. I think the downside is that that's great for the things. What we mustn't do, what the medical profession mustn't do, is to go into a fixing mindset where if you can't fix it, you don't want to know. Because we can't fix everything, and people are still suffering with the things that the research isn't being done or isn't being successful in. Or we may have problems diagnosing it. People who don't fit into a clear diagnostic category and they've got some problem and they go from doctor to doctor and nobody can say what's wrong with them, or everybody says a different diagnosis. And I think it's important with those people always, there are patients who come to us, and of course we're delighted with the people that we can make it clear diagnosis. Yeah, I know what this is. Oh, that's wonderful, doctor. I've been looking for 20 years. And oh, and not only that, we've got this wonderful new tablet. Let's try. Oh, it worked. Aren't we? We're all so happy. That's great. Okay, that's in a way though the easy bit of being a doctor from my side.
Mm-hmm.
The hard bit is when you're not quite sure what's wrong with the person. What is the diagnosis? How are we going to help them? How and if the situation is, that they may not fit into any of the standard diagnostic categories, how are we going to help them? And, we don't then get rid of them as a failure because we failed. Do you see what I mean? Which is very tempting for doctors who sort of say,
Right.
well, my job is to fix. So if I can't fix, I'm not interested. We still go to our the old job of saying, come on, we're here to look after people. We may have technical problems in this particular case in doing the fixing, but we have to be carers. I mean, that's what it's about. And I think that with the wondrous things that are happening with the high tech, it's fantastic. I mean, I find it incredibly exciting that things are moving on, and that you suddenly have drug trials and you have drugs and all over medicine. It's not just porphyria. Porphyria is definitely a good example of this. I mean, with the acute porphyria drugs and now some of the cutaneous porphyria drugs are fantastic, but that there will always be things that are still in the shade, that are still not so well understood, that are still not so easy to diagnose, that we're still not so good at dealing with. And then, just go back to what, a doctor would have done, a few thousand years ago. Sort of try and, understand and try and help in whichever way you can. And I think one of the problems that's happening with technological medicine is that sometimes that's forgotten. That's all I'd say.
Yeah, it's a very understated point, I feel like, because I think there's a lot of people out there that just wish that their doctor would just start with, "Hey, how are you doing?"
Yeah,
And yeah, I feel like that just doesn't happen because it's right into the numbers, it's right into this, and yeah, the soft skills may lack, they may not, but yeah, I think we talk about this a lot with doctors and the hardship for a rare disease patient to be able to go to a doctor and be like, help me. And obviously it's situational. They're not all brushed with the same brush, like you said, but some may not be willing to do it. Others are like, I don't really know, but I'm willing to try and understand. And I think that's the real key, the real difference.
yeah, and validate. I mean, suffering. People. It is a human need that if you're suffering, you need some validation. I mean, the reason why people get so upset by, you know, deny. When people say, there are people with whatever condition is, and there are some which have been difficult to sort out medically. In terms of what's going on, and then you get angry groups of patients with those sort of diseases, where it's not clear what's going on, um, um, and the anger, a lot of it, when you listen to what they're saying, is around, I'm suffering here, and I've been told it's all in my mind, or whatever is the phrase. Do you know what I mean? I've been suffering in it here, and and it's simply the lack of validation of saying, we get it that you're suffering, and I'm sorry that you're suffering. Let's see what we can do. But I think the acknowledgement of sort of saying, you know because we can't come to a clear-cut diagnosis, this is not really a porphyria relevant discussion, but there are situations, where you can't come to a clear-cut diagnosis, and there's nothing wrong with you, is the phrase that I hear repeated back from me from patients. Well, of course, there's something wrong with them. There's enough wrong with them that they're going from doctor to doctor saying, please, my life is in ruins. I can't work. I can't do this and that. The fact that we say, okay, the technology, the understanding as of 2025 doesn't necessarily extend to this particular thing, doesn't mean that we don't say, you're suffering terribly. Let's have a think what we can do about it. But just validating that suffering is an important part of the job.
Yeah, and I'm sure there's a toughness to it too, because I know there's a lot of people that maybe don't have that mindset to treat everybody differently in a sense, because I know you could probably get a line of people who maybe are in that drug seeking category. I don't know, and
Yeah.
then maybe they go into it with that skewed chip on their shoulder mentality, and they kind of have that in their mind when somebody else comes in the door, and then obviously you're throwing things like it's in your head, you're drug seeking, it's anxiety, or with the acutes you probably just have IBS. So it's just one of those things.
It's tricky, but it's. I mean, it's a very enjoyable way to spend your professional life, from my point of view. And no, I mean, clearly, being able to make a diagnosis and to make a difference when there are great treatments around, and that's the ideal. That's fantastic, and that, I think, maybe where, we're not there yet, but that may be where we're going with some of the porphyria stuff. So it's just very optimistic. Fingers crossed.
Yes, fingers crossed, because that it sounds like there's a lot on the horizon, especially for cutaneous porphyrias. So I'm definitely excited to see that from afar at how the treatments come to be, and how many lives it changed. So and
Yeah.
it's awesome that you're a part of it too.
Yeah, no, it's exciting, and yeah, I mean, the other role that we play, is sort of, people with variegate porphyria, for instance, might come to us first with their skin, and then, it's important that the doctor clearly has the recognition that, okay, the skin problem, let's deal with that and whatever, but the more important implication of this is that you need to see somebody who knows about acute porphyria, because actually you've got a risk of developing acute attacks, that sort of thing. So the skin is often, generally for dermatology, there is a part of dermatology which is seeing in the skin reflected some sort of internal things that may be significant to general health, not just to skin health, And variegate porphyria is the classic example, really, for in the porphyrias. But then so are the liver, complications of EPP, and the liver complications of PCT, and the hematological complications of CEP. But sort of generally in dermatology, that's part of the job, and it's pretty important to say, actually, not only we need to fix your skin, but this tells us that we've got to think about something else as well in health.
It's just crazy just how the body works, and sometimes you can sit back and just learn more about it, but it's just something's happening here, it's affecting this, and it's just this domino effect of things. So yeah, it's almost like you almost have to be well rounded in the internals and the externals to be able to truly make that diagnosis and
True. And of
understand.
course, there aren't many bits of the body you can actually see. You can see the eyes, you can see the skin, and the bits you can see, it gives you an advantage. If you're going to find out what's going on in your bowel, you have to have a colonoscopy, or something to do that, or an MRI scan of your brain. But I mean, on the skin, you just have to look carefully.
Mm-hmm.
So that is quite useful, because there's one organ, eyes are similar in a way, but definitely the skin, where you can see exactly what's going on easily, and it may be telling you that something similar is going on in the heart or in the brain or in the wherever.
I know definitely got yourself a busy schedule, so I definitely appreciate you carving out this time, and I can't wait for everybody to see and watch this, because it's very eye-opening to learn more about porphyrias, the history, how it more affects your liver, and people just sometimes don't realize the full circle of how everything kind of happens. So I appreciate that.
Yeah, no, thank you very much. Thank you for inviting me.
Thank you for taking the time out of your day to listen to our podcast. If you enjoyed this episode, please share it with friends, family, or anyone who could benefit. And please don't forget to subscribe and leave a review on your preferred platform. It helps us spread awareness, and we would be extremely grateful. You can also follow Rarely Discussed on Instagram, YouTube, as well as TikTok. If you're someone seeking diagnosis for porphyria, visit porphyriafoundation.org to receive a free doctor packet, forms for free DNA testing, and a list of doctors in your area. Stay tuned for more episodes of Rarely Discussed.